Vidal here at Pure Plastic Surgery. This is our weekly check-in to discuss different topics in plastic surgery and more importantly answer all your questions. Today we are discussing breast procedures. The reason for that is because we're in October, Breast Cancer Awareness Month. So we'll go and discuss a little bit about all the breast procedures or the most common breast procedures that we do, which are three: breast augmentation, breast lift, and breast reduction. So I'll go over each procedure, the differences, and then we'll get to some questions about breasts, okay? So breast augmentation, breast lift, and breast reduction, what is the difference? It's basically what the goal of the procedure, okay? So breast augmentation, the goal is to augment, is to add volume, okay? It doesn't change or it doesn't dramatically change the shape of your breast. It doesn't dramatically change the position of your nipple. The size of your nipple stays the same. It's basically adding volume, okay? With an implant, it can be saline or silicone implant. A breast lift is a procedure mainly to reshape your breast. Why? Because it's mostly for patients that had either a pregnancy, breastfeeding, massive weight loss, aging, gravity changes, congenital, that just your breasts are like that, and the breast, instead of being more circular and lifted or plumped look, it is elongated, deflated, the nipple position is altered, okay? So the goal of the breast lift is to reshape the breast, and it usually targets several things: nipple position, nipple size, breast shape, okay? What are the different incisions of a breast lift? There are three types of breast lift, or three types of incisions. One is just goes around the areola, that's a donut lift, or peri-areolar, just goes around the areola. For those type of breast lift, the nipple position can only be lifted very little, okay? So it's for patients that don't have a lot of ptosis or droopiness, and I'll talk a little bit about the ptosis degrees in a bit. The other or second type of breast lift is what we call a lollipop type of incision. It goes around the areola and down, not the across one, just down, like a lollipop, okay? So with this one, we can increase or move the areola position a little bit higher than with the donut, but it doesn't alter the shape of the breast in the round aspect of it. It just lifts the breast and takes a little bit of skin from the bottom aspect, but it doesn't have a lot of power with reshaping and rounding the breast, tightening the pocket. And that is why the anchor type of incision gives us a little bit more flexibility when you have more loose skin and you have to lift the nipple position more, because it allows you to increase or move the nipple position higher, but also remove excess skin from the lower pole and lift, tighten, but also reshape and round the breast, okay? When the breast droops with pregnancy, with massive weight loss, when it droops, it tends to change the shape from round to a more elongated breast. And when we're doing the lift, we're trying to reshape it and round it again, okay? So that's why the anchor gives us more flexibility and more room to tighten it in the roundness part and make the breast round, okay? A breast reduction, it's when we're trying to remove tissue, okay? So we're trying to reduce. So the goal of a breast reduction, it's different than a breast lift. The incisions might be the same. A breast reduction can be done through a lollipop, but more commonly and usually needed is an anchor type of breast reduction. The reason for that is, like I said, with the breast lift, it allows you to remove more tissue, which is usually the goal of the breast reduction. Remove breast tissue and reshape it and tighten it. With a breast reduction, the goal is to reduce the size because it's usually causing problems. Breasts that are large and heavy usually are causing neck pain, shoulder pain, pain in your shoulders where the bra strap grooves lie, and usually have like indentations. People have indentations in their shoulders because the bras are too heavy. Rash under your breast because the breasts are folded over and causing rash in that area, and inability to wear the clothing that you want. It's very hard from some women to get a bra that fits, shirts that fit, a dress that fits. So all of those are indications to get a breast reduction, okay? A very common question that I get is, can I do a breast reduction and add an implant? Well, we're doing two things that are opposites here. The bottom line is, yes, it can be done, but usually the goal is the goal of a breast reduction is to reduce the size. And when we're adding an implant, even though most of the people, and I understand, they want the cleavage part or the push-up look bra look, with a breast reduction, it's hard to combine those. It can be done, but it's in very select patients, okay? The reason for that is to avoid one of the possible complications that I'll be talking about in a bit, which is nipple necrosis. So in short, the answer is yes, it can be done, but it's usually for very select patients, okay? So those are the three most common procedures that we do: breast augmentation, breast lift, and breast reduction. And the three differences between them, okay? A breast augmentation, like I said, it's for people with no ptosis or grade 1 ptosis. So let's talk about ptosis. What is ptosis? Ptosis is droopiness of the breast. It is described by the position of the nipple when you compare it to your IMF or the inframammary fold, the fold that is below your breast, okay? So how do you know what grade of ptosis you have? You can stand in the mirror sideways and take a look at your nipple position in comparison to your fold, okay? If you don't have any ptosis, the nipple should be above the IMF, above the fold, like you see right here, okay? Grade 1 ptosis is that the droopiness has taken that nipple to be at the level of the IMF. Sometimes it helps if you put your finger in the fold and then you see where your finger is in comparison to your nipple. So grade 1 ptosis is at the level. So it depends on the shape of the breast and your goal with a breast augmentation, but a breast augmentation can be done with no ptosis or grade 1 ptosis, okay? But like I said, depends on how much tissue you have. Usually for patients that have grade 1 ptosis and want to avoid a breast lift or the scars of a breast lift, then I recommend going with a bigger implant, okay? Why? Because when we fill the space, that's gonna fill the space of the breast, and if the shape is adequate. So that's one of the things that is very important. And I have a lot of patients that say, Dr. Vidal, but I just have grade 1 ptosis, why can't we just put an implant? It all depends on the shape of the breast. If the breast is very elongated, even though the nipple position is at the level of your IMF, putting an implant is not gonna look good, okay? If the breast shape is still round and your nipple is at the level of the IMF, we can put an implant and try to reshape the breast with the implant. But the implant needs to be usually a little bit bigger because we're trying to fill the space out and try to push that nipple position up. The way of trying to push that nipple position up is by doing the procedure, doing what is called a dual plane. So it's basically putting the implant behind two planes. That's dual plane, right? But in the upper part of the implant, so if this is the implant and you're looking at sideways, in the upper part of the implant's going to be behind the muscle. But I release the muscle from the bottom of the chest, so it rises and it lifts the nipple position with it a little bit. So the implant in the bottom part is behind your breast tissue. So that's what's called a dual plane. And you can see it right here in this little diagram. You have the implant, the muscle, it's this very thin reddish brown area here, and then you see the breast tissue is the yellow one. So you see in the dual plane, the upper part of the implant is behind the muscle and the lower part of the implant is behind the breast. So if you have a little bit of ptosis, I'm gonna probably recommend you put the implant in a dual plane type of pocket, okay? The other type of pocket that I usually do for my patients is the subfascial. Subfascial means that all our muscles in our body have a thick layer that is called fascia. That's basically the coverage of the muscle and provides strength, okay? So when we're putting the implant, subfascial has the benefit of the strength and keeping the implant away from the breast tissue, but I don't have to raise the muscle with it, okay? Raising the muscle always has a little bit of pain related to it, and it can have what it's called animation deformity. Animation deformity is that when you're moving your arms, the muscle contracts and the implant moves. When I'm putting it under the fascia, because I'm not raising the muscle, that's not going to be a problem, okay? Why not everyone is a candidate for a subfascial? It's because you need good breast tissue coverage, okay? Because if not, the implant is just going to be behind skin and fascia, which is very thin, and you might be able to feel and palpate your implant, especially on the upper part of the breast. And when the implant goes like it's pushed in the pocket, it might have these folds that you see, and that it's called that, and that you may feel a little bit. If you're very thin and you don't have a lot of breast tissue, then it's better to put it under the muscle to avoid feeling or even seeing this through your skin, okay? So if you have more breast tissue to cover this, then you won't be able to feel it or see it because your breast tissue is going to be over it, okay? So those are the two most common places where I put the implant. The other place that is very common is to put it behind the gland or subglandular. I don't like to put it behind the gland itself because it doesn't have that coverage of the fascia, but it is a common place to be put also. Where are the incisions for a breast augmentation? The two most common incisions are the one in the areola or periareolar, is like half of the areola or less. It's cut to provide access to put the implant in, or in the fold, IMF, okay? And you can see it here, the fold or the areola. Through the axilla, I don't do it. Through the axilla, the problem is that has an increased rate of infection, increased rate of capsular contracture, and because it's far away from the area that you're trying to work, you have less control of the pocket, okay? So implants may be a little bit asymmetrical, a little bit lateral, because you don't have that control of putting it exactly where you want to put it, okay? So that's why I don't like to do transaxillary or through the axilla. Areolar, because we're going through the ducts of the breast, there is an increased risk of capsular contracture when compared to the fold, okay? And the fold, it's a very small incision. When you put the implant, that fold gets hidden below. So that's my preferred way of putting an implant. Through the fold, small incision, usually hides very well, and the rate of capsular contraction is a lot less. So that's my go-to incision, through the fold and putting the implant either in the subfascial plane or dual plane if you have a little bit of ptosis, okay? So those are the patients that will benefit from a breast augmentation. Those that have grade 2 or grade 3 ptosis, they're gonna need a lift. So what is grade 2 or grade 3? It's when the nipple is below the fold, okay? So again, if you're putting yourself like in front of the mirror, checking yourself, putting your finger in your fold and checking where is the nipple in comparison to your finger. If it's below your finger, then it's a grade 2 ptosis, and that means we're gonna have to do a lift. I have some people that say, I don't mind the droopiness, just put the implant and I'm fine. The problem with that is your breast tissue is not where the implant is going to be. The implant is gonna be in your chest because I can't put the implant flying in the breast tissue. So the implant is going to be in the pocket in your in your chest, and then your breast tissue is going to be hanging. So you're going to have what is called a double bubble deformity. Double bubble, one bubble is the implant and one bubble is the breast tissue. They're not going to be in the same spot. So that's why it's not advisable to put an implant in a patient with grade 2 or grade 3 ptosis without doing a lift. It's not gonna look good, okay? I have a lot of patients say, I don't mind the droopiness, I just want more volume. The problem is it's not gonna look like you're thinking. The implant's not gonna be below the breast. It's gonna be where in the pocket and the breast tissue lower. It's not gonna look fine. So that's why grade 2 and grade 3 ptosis need a lift. Type of lift depends on the shape of the breast and the nipple position. Usually grade 2, grade 3 ptosis are gonna need either a lollipop or an anchor type. Usually because the shape of the breast is elongated and we need to reshape it, an anchor type of lift is the usual approach for me to reshape the breast. I think that the results are a lot better. The shape of the breast is a lot better, and also I have more control of what we call the lower pole of the breast. When we're doing a lollipop, usually the lower pole of the breast or the breast that is below your nipple tends to get very long. And sometimes the nipple tends to look up with time once the implant settles. When you're doing the anchor type, it looks better because you have more roundness and you can control that nipple to IMF or nipple to fold distance better, okay? So that's why you'll see my patients usually have an anchor type of lift. It's because I do think that it provides the better reshaping of the breast. And also the fold incision, it's very well hidden. So the actual incision that you might see with time is the vertical, and that you have it with a lollipop. The fold incision is usually hidden very well, and most of the time you don't even see it because the breast kind of hides it, okay? Grade 3 ptosis is when the nipple is pointing down all the way, okay? So those are gonna need an anchor type of lift. So when to combine a breast lift with an implant? It depends on your goals, okay? A breast implant, like I said, it's going to add volume. So if you want to reshape the breast but add volume, then you're gonna need a combined breast lift with an implant. The tricky part of this procedure is that we're combining two procedures that are actually doing the opposite. A breast lift is tightening it, and a breast implant is adding volume. So we do have a limit of how big of an implant we can put. So sometimes I have patients that come, I want a very big augmented look, and they have grade 2, grade 3 ptosis. Well, I'm gonna let you know right away from the bat that you're gonna need 2 surgeries, okay? The first surgery is gonna be the reshaping of the breast, and we can put an implant, but I cannot put an implant that it's too big, that it's gonna put tension on the closure and cause it to open up and have infections and implant loss. And the other one is puts too much pressure on the nipple and you can have nipple necrosis. Let's talk a little bit about nipple necrosis. When we're doing a breast lift or a breast reduction, I don't detach the nipple and put it up. The nipple is still attached to the breast, but I need to rotate it up, okay? When I do that, the blood vessels, the circulation to the nipple comes from the chest. So when I'm rotating it, and if I put a lot of tension to it, then we can kink or impede the blood flow to the nipple, and we can have nipple necrosis, okay? It's a very rare complication that it can happen. The thing that increases the risk of having nipple necrosis is the nipple distance. So that the distance between your neck and your nipple is very long. So if that distance is more than 30, I'm not going to advise to put an implant when we're doing the lift, because that, you can imagine, the blood vessels come from the chest. If that distance is very long, that means that those blood vessels have to travel a long way, and when I rotate it, they can kink more easily, okay? So if that's the case, I'm gonna advise you to do 2 surgeries. Let's do the first one, reshape the breast, and then on a second one, once everything is healed, then we can put an implant, okay? All of those, I know that nobody wants to hear I need 2 surgeries, right? But safety for me is my #1 priority. This is an elective procedure, so keeping it safe and keeping you away from complications is my #1 priority. So I know that with that distance being long and with the risk of nipple necrosis and losing your nipple being too high, I'm not going to advise you to do it. So those are the reasons when I say you'll need 2 surgeries, is to avoid nipple necrosis and avoid the incisions opening up and then causing the implant to get exposed, get infected, and we need to remove it. Okay, so grade 3 ptosis usually depends like on the length. Like I said, they might need staging the breast lift with implants, but I have a lot of patients that if we go with a very small implant and they don't have a lot of breast tissue, it is a possibility. It's all very individual, and that's why your initial consultation is so important. Okay, and what types of implants? So implants come in saline or silicone. Okay, they're both very safe. Usually I use a lot of silicone implants because the silicone implant feels more natural than the saline implant. Saline is just a water-filled balloon, so you're gonna feel it more like that. This feels more soft and more similar to breast tissue. If you have a lot of breast tissue, the implant is gonna be behind it, so you might not find very much of a difference between saline and silicone. But if you don't have a lot of breast tissue, and when you're palpating your breast, you're gonna feel more your implant rather than breast, then yes, it's gonna make a difference, the type of implant that you choose, okay? The other reason is, like I mentioned, this folds, it's called rippling. This folds that the implant does, it's more common with saline than with silicone, okay? And the other thing is, if it ruptures, saline will deflate immediately because it's filled with water. Silicone will keep its shape, okay? So that means it's good because you won't see a difference and you have time to plan for to plan for an exchange. You don't have to run because you have an asymmetric breast. But the bad thing or the downside to that is that you do have to be checking for rupture because you're not going to know. So the FDA recommendation, if you get a silicone implant, is to get an ultrasound or an MRI 5 to 6 years after you get your implants placed, and then every 2 to 3 years to monitor for rupture, okay? Once it's ruptured, it's not an emergency. You don't have to be running away, like running right out and getting them out, but it should be exchanged because the rupture just keeps an inflammatory process in the area, so it increases the risk of having capsular contracture and inflammatory processes in the breast. Sometimes it hurts, sometimes it gets harder, so it's better to change it. Again, it's not an emergency because these implants are called the gummy bear type, so they're gonna keep their shape. It's not fluid on the inside. It's like a gummy bear. It keeps its shape, but it's not, if the capsule is broken, then it should be changed. So not an emergency, but it should be changed. So if you do get a mammogram and ultrasound and see that your implant is ruptured, then you should make an appointment with your plastic surgeon to get them changed, okay? The post-op of all the breast procedures are very similar in terms of the restrictions and the recovery. Breast procedures are not very painful, so you're not going to be, there's not going to be a lot of pain involved. It's usually, my patients describe it as soreness rather than a lot of pain, stabbing pain. When you put an implant, it's a little bit more painful if you're putting it under the muscle because you're stretching that muscle, but again, not too painful, more tension. Because of the incisions and because of the implant, I ask my patients not to elevate their arms above your shoulders for the first 2 weeks. So we call it T-Rex arms, to try to keep your elbows close to your body for the first 2 weeks to avoid tension in the areas of the breast. And then I'm going to ask you to avoid exercising, heavy lifting for 6 weeks. For all the patients with incisions, I'm going to ask you not to shower for the first 2 days to avoid getting the incisions wet, avoid infection. Afterwards, you can shower, but not submerging yourself in water. So no bath, no pool, jacuzzi, beach for 6 weeks until everything is healed to avoid those incisions getting infected, okay? And the scar treatment, to try to get those scars to heal as nicely as possible, you're going to start at 2 weeks post-op, and that's in all the incision patterns. I recommend my patients use silicone-based scar treatments. Those are the ones that have been proven to improve the scars. The one that we sell here is called Incision. It's very good because it's 100% silicone concentration in it. Some scar treatments that you see over the counter or you see on Amazon and other stores, they don't contain, the content of silicone is not that high. So when you're checking for scar treatment, just check the concentration of silicone, which is the important component of it, okay? And that's pretty much it. If you guys have any questions, I'll be happy to take them.
Yes. Let's move.
Yes.
Okay, I have money here. Let's read. Okay, and I am due to have Lipo 360 with you in October, or a year ago. I had a BBL now. I want to have breast reduction with implants or not, but I was told my BMI was too high.
Yes, so it's very important that you have a BMI of less than 33.5. The reason for that is because the risk of infection increases and the risk of other complications such as wound healing problems and blood clots in your legs, and also pulmonary embolism, which is one of those blood clots getting to your lungs, is higher. So you can do it. You just get on a diet, exercise regimen. You can do it. Lower that BMI to less than 33.5, and we can help you out.
Okay, this one. If request by patient, do you give something for the spiked nerves on surgery day? Regards.
What, for nerve pain?
For spiked nerves?
Nerves? Yeah. So yeah, I mean, for nerve type of pain, I usually don't prescribe anything right away. There is a medication called gabapentin that is very good and works very well. Like I said, this procedure is not that painful, so usually I don't like to prescribe it to all my patients, but I've had patients that in the post-op period, they have those type of nerve pain, which is like tingling sensation, shooting pains, which is common for everyone to have it, but sometimes it gets a little bit more than the usual post-op pain, and I've had prescribed gabapentin for those type of pains, but not usually for everyone, as like I said, it's not very usually a very painful procedure.
Okay, how long does it take to go back to my normal routine after a Lipo 360 and BBL, like work and gym?
So for gym, 6 weeks. So I don't recommend going to the gym or starting exercising for 6 weeks after basically any of my procedures. To work, that depends. It depends on what do you do for a living. If you're working from home, then maybe a week. If you are working behind a desk, then I would say at least 2 weeks, because you're not going to be able to sit without a BBL pillow until you're 2 weeks post-op. So if you're kind of desk work and you can work with a BBL pillow, then I would say at least 2 weeks. But if you're in a very active job and you have to be moving around and lifting things, then that depends. Sometimes you have to wait 4 weeks to feel better and to feel and have more strength to get back to your daily living. But if you don't have a way that they can do light work for you and you have to do heavy lifting, more than 10 pounds, then you're gonna need to wait 6 weeks to return to work.
Okay. Okay, the next question is, are there any natural-based scar healing products? I heard silicone isn't the greatest for our body.
So silicone, you're not going to inject it and you're not going to put it topical. So the side effects of topical silicone is it's minimal. Silicone is the only medication that has been proven to improve the appearance of scars. There are a lot of natural-based products out there for scars, including vitamin E, that a lot of people use and a lot of scar products have, but again, none have been proven to be beneficial. So bottom line is, my recommendation is that you do use a silicone base. That avoiding sun exposure is another thing that is extremely important for scars. So using sunblock over your scars is very important. And then you can add any other natural product that you feel or that you've heard that helps. It's fine. But me, as a medical recommendation, the only thing that I can recommend that works, it's silicone-based products. Okay? Awesome, you guys. So I hope this helped answer a lot of the questions regarding breast procedures, especially between breast augmentation and breast lift. Should I get an implant? Should I not? And all of those questions. This is going to be in my Instagram page and also YouTube channel, so for you guys to review later on. And thank you so much for joining. I'll see you guys next week on Tuesday Tips.
Friday in Spanish.
Oh, right. We are doing a Friday live en español. So los viernes son nuestro día de hacer historias y hacer cositas en español, y este viernes voy a estar haciendo un live en español. Lo voy a hacer también de procedimientos de seno para estar en la misma página, así que cualquier pregunta, cualquier cosita específicamente que quieran que toque en ese live, me lo escriben por mensajito y nos vemos el viernes. Okay guys, bye bye, see you guys Friday and also next week on Tuesday Tips.